In our last video, we looked at the equation for clearance, right? And we kind of learned how to apply it for things like figuring out the glomerular filtration rate, figuring out renal plasma flow, and all that came together to help figure out filtration fraction. We did two questions. We did this question up here, which was just a straightforward question asking about the best estimate of the filtration fraction, right? And the best estimate of the filtration fraction came out to about 20%, but it required us to combine the two equations, right? Combine GFR clearance, renal plasma flow clearance, and then take their ratio to get the filtration fraction, right? And then there was this question down here, which was just about the renal plasma flow and how you can use renal plasma flow to figure out renal blood flow if you're given the hematocrit. And then you can use renal blood flow to figure out cardiac output. So everyone knows the standard equations of figuring out cardiac output, but using renal blood flow to figure out cardiac output is a whole different level. And even more so, using renal plasma flow and PAH clearance to figure out cardiac output is what you want to be very comfortable with. And it wasn't so hard at all. So we did this question down here as well. Now, what I want to talk about next is the topic of nephron physiology, right? How do your nephrons really work? And what do they do, and how do they adapt to things? So one of the things about the nephron that's really critical in human survival is the ability to adapt to water deprivation, right? So you're going to often get questions while you're preparing for step one. You're going to see questions where a patient was dehydrated, either because they got stuck in a cave or something, or someone got lost on a big trip they were going on, or someone got stranded somewhere. Whatever the story might be, water deprivation is going to be the main point over there. And then they're going to ask you how your tubules are going to be adjusting, right? So just for repetition, previously we talked about a certain part of your kidney being very susceptible to hypoxic injury, and that was the medulla. Right? And we talked about how the descending and ascending limbs, this loop of Henle area basically, is the part that's going to be injured if someone has prolonged hypoxia in the kidney, right? Because the medulla is very susceptible to hypoxic injury. And what we're seeing here in the left image, this is an image from UWorld, where they color-coded how permeable that part of the nephron is to water. Now, your PCT is practically permeable to everything, right? So you can see your proximal tubule and the descending limb are green for high permeability to water, right? So water can be reabsorbed and you can retain it, or if you have too much water in your body, then you can just filter it and secrete it. The distal convoluted tubule and the ascending limb have no water permeability. Okay, so the only thing that moves in this area is your solutes. Right, your solutes are going to be reabsorbed or secreted as necessary. And then the late DCT and practically just the collecting duct is the main guy that you can control as necessary. When we were looking earlier, I just want to find, okay, so when we were looking at the macula densa stuff earlier, we were talking about how, the JG cells and the macula densa, the JG cells are near the afferent arteriole, so they can see what's coming, but they work using the macula densa, which is on the DCT, so that, whatever came has already passed the macula densa, but by the time all that stuff reaches the DCT, you can do something about it. And that's what's falling into place right here, right? So whatever was seen here, if you didn't like it and you want to do something about it, you can do something about it by the time it gets here. It gives your body enough time to actually, fix things up as necessary. Also keep in mind that although nephrons are drawn like this often, this isn't how they really are, right? Nephrons are really like this right side of it. So you can see how your glomerulus and the afferent and efferent arteriole are all very close to your DCT, right? The distal straight tubule. All right, so it's not supposed to be pointing out, but rather pointing in. But it's drawn like this just for anatomy purposes of explanation. So what's going to happen now? Look at this image on the right from the internet. they're showing us the osmolarity of the interstitial fluid, the fluid inside the lumen, as it's traveling through the nephron, right? And at different parts, it's different amounts, but whatever is in here is what's going to get urinated, right? So you can see it's 300 in the beginning, which is about normal, right? Remember 290 was the normal osmolarity, so it's about normal at 300 over here. And then as it's going through your PCT and descending tubule, you can see that the osmolarity is increasing, which means the solute concentration inside the tubular lumen is increasing. And that's because you're reabsorbing all your water, right? That's what you normally want to do, and you definitely want to do it in the cases of water deprivation. This image on the right side is for water deprivation. So you reabsorb all your water, which means all that's left in the tubular fluid is just a bunch of electrolytes, right? All your solutes. So the solute concentration reaches a maximum of 1200, right? Then you get into the non-water permeable part, the DCT and the ascending limb. And what you're going to do here is reabsorb any key solutes you needed, right? So you can see here they're showing you you're reabsorbing sodium, NaCl. So again, the concentration, the solute concentration is decreasing. So now your osmolarity goes extremely low to about 100. Now, in the very end, right, where you can actually adjust how much water reabsorption you do, because you can see this orange area is variable. If you have high ADH, you're going to have high water permeability because anti-diuresis, you're not going to diurese. And if you have low ADH, which means you have enough water in your body, you don't need to reabsorb it, you're going to have low water permeability and you're just going to urinate all the water out. In water deprivation, as is seen on this right side image, you're going to reabsorb all your water, thereby what's the word I'm looking for? Reestablishing that same hypertonic 1200 osmolarity because you took all the water out. So all that's in here is just solutes. So this guy's urine, if you look at it, would be really, really dark yellow, and it would not be diluted at all because you didn't urinate any water. This guy's not going to urinate any water. He has water deprivation. So you can see tubular fluid osmolarity in the setting of high ADH in water deprivation. The numbers given are exactly what can be tested for in a patient who is dehydrated. In a patient who is dehydrated. So PCT 300, descending 1200, ascending 200, DCT 100, and then CT 1200 again. Right. So basically, the numbers are very small up here and very big down here. That's all you really need to understand. Without ADH, the osmolality in the collecting tubule would remain the same as it was in the DCT, about 1 to 300, right? Hence, with ADH, you get isotonic PCT, right? So you need to remember these words in this order because it's pretty critical. So with ADH, you're going to have an isotonic PCT, right? This is isotonic. And then hypertonic limb is going to have high tonicity because you took all the water out. A hypotonic DCT because now you took all the solutes out. And then again, a hypertonic collecting tubule or collecting duct because you once again took all the water out, right? So the hyper and hypo are directly related to the value of the numbers, and it's just going to be a very small number at the upper portions up here, a very big number at the lower portions down here. That's all you need to understand. So when you get a question asking you, what would the tonicity be at different parts of a nephron in a patient who is dehydrated, this is what you would say. In the PCT, it's going to be a very low osmolarity, so it's going to, it's just going to be isotonic because PCT, remember, is the place where you have full movement of everything. Everything is permeable. So isotonic PCT. In the limb, it's going to be hypertonic because at that point you were reabsorbing water. At the DCT, it's going to be hypotonic because you're reabsorbing solutes. And then again at the collecting duct, hypertonic because you're reabsorbing water. Right? Very straightforward stuff. This is just nephron physiology in the works, trying to keep you alive and hydrated when you're just stranded somewhere and don't have any water. Or even going through a normal day of fasting, right? That's another thing that you can get in a scenario. Someone who might be doing a religious fast or just doing a fast for health purposes, whatever it might be. You want to make sure you understand that. So down here, there's a little more explanation. You can feel free to check it out as you wish, right? So I talked to you about what happens at different parts of the tubule and what parts are affected by the ADH. So really important to really make sure you can grasp that information. And then this is an image from Amboss, kind of showing you more of, how the entire thing looks like. So here you see one entire papilla, right? One entire papilla with your inner medulla, which is very susceptible to hypoxic injury. The outer and inner portions of the medulla over here, right? So the outer medulla has this outer and inner breakdown to it. And then the renal cortex, which is very well, heavily blood supply, so it's not going to have any issues there. And here they zoom into one specific nephron set, so you can see your efferent and afferent arteriole coming into the glomerulus, which is literally hugging your distal straight tubule. Stuff is going through the PCT, then the proximal straight tubule comes down into the loop of Henle, goes back up here. This thicker portion here is not permeable to water. Okay, that's the stuff we were talking about earlier. And then it comes back into your collecting tubule, which finally gets, into one collecting duct that's all going to, in the end, come down to dropping everything in the bladder, right? So you can pee it all out. And you can see the vasa recta and all the different blood supplies that we've talked about. You have multiple glomeruli all coming into one collecting duct. That's another scenario you want to make sure you understand. And that's all I'm really talking about right here. The presence of brownish or muddy granular renal tubular epithelial cell casts in his urine is evidence of acute tubular necrosis, the cause of 85% of intrinsic acute kidney injuries, and most commonly the result of ischemic change to the PST and or TAL, right? PCT, PST, and the thick ascending limb. Basically, here we're just talking about, what can happen in terms of damage. But if you ever see granular renal tubular epithelial cell casts, that's a sign of acute kidney injury, and you want to make sure you remember that. When we get to pathology, we're going to see all the different kind of casts that there are. The next topic here is filtration. This is what we did some questions on last time, right? So nothing crazy here. We have filtration fraction, which is GFR over RPF. Normal filtration fraction is about 20%. And the filtered load, another equation you can add to your cheat sheet, the filtered load is GFR times plasma concentration. Right, so if you can calculate GFR, you can calculate the plasma concentration, you can solve the rest of it. Where is this? Okay. So GFR, as we saw earlier, can be estimated with creatinine, and renal plasma flow is best estimated with pod clearance, and we did all of that last time. And that's how you calculate filtration fraction. We already saw an example on that in the last video. Now for the filtered load, this is just the load of everything coming in here to get filtered. That's your GFR times the plasma concentration, all right, of whatever it is that you're trying to figure out the information for. Because remember, GFR, you're going to calculate with clearance, and usually clearance for creatinine. So maybe you're looking at the filtered load of creatinine to figure out the whole filtered load. And in terms of terminology, right, filter, as you can see right here, filter basically means you are putting it into the tubular lumen to pee it out. Right? So whatever's filtered will eventually get excreted unless you reabsorb it or you add more into it. Right? So these are the four terms that you often see being used when talking about how everything is going through a kidney. And the afferent arteriole brings things very close to the JG cells. The JG cells can then use the macula densa and the distal renal tubule to adjust things. By the time blood flows through here and everything gets filtered and whatnot, stuff is going to reach up to here, right? This yellow lumen is the same lumen over here. Don't forget. So whatever is being filtered, if let's say for example here at this point, the blood that came in has a very high osmolarity. Very high osmolarity. That means that the blood that came in here basically has a high solute concentration. Your JG cells are going to recognize that. They're going to work with the macula densa and whatnot, and they're going to try to make sure that you fix that. So by the time stuff reaches here, if everything had a very high solute concentration, you're going to make sure you don't reabsorb more water. You need to pee out more water so you can dilute your urine. And that's the whole concept of why JG cells and the macula densa are over here and not anywhere else. Why they're not here or in the collecting duct or anywhere else for that matter. They're right here because this is the perfect place to put them so that they have enough time to work with everything that's in this lumen. By the time it's coming up here and reaching the collecting duct, your body's going to be ready. Your kidney's going to know whether or not you want to reabsorb that water. Now, we're going to see medications, right? Prostaglandins and angiotensin inhibitors. prostaglandins dilate the afferent arteriole, PDA, and ACE, angiotensin II, constricts the efferent. ACE inhibitors stop that. And NSAIDs, which are antiprostaglandin, NSAIDs stop this. So you really want to make sure you understand that too. These are the two things being mentioned up here. So up here and down here. NSAIDs, you see prostaglandins preferentially dilate the afferent arteriole. What does it mean if you dilate the afferent arteriole? So dilating the afferent arteriole will make this wider. And if you dilate the afferent arteriole, more blood will be coming in here, right? So if you do that, everything increases. More of everything is going to come here. So you're going to have more renal plasma flow and more GFR. So your filtration fraction will not be affected, because remember, the filtration fraction is just a ratio of your GFR divided by RPF. So if they were both maybe 10 and 10 before, or let's just make up better numbers, but I'm just giving you fake numbers for argument's sake. Let's say filtration fraction was previously like 10 and 20, right? So 20 divided by 10 is just 2. Now they're both going to increase to 20 and 40. It's still going to just give you a ratio of 2, right? So filtration fraction is not going to change when you take prostaglandins, nor will it change. What the fuck? Nor will it change after you start taking NSAIDs, right? Because that's just going to cancel this out. Filtration fraction will still remain the same. Down here, you're seeing ACE. So angiotensin II preferentially constricts the efferent arteriole. Now, this is a little more complicated to understand than this upper portion was. If you constrict the efferent arteriole, that means that whatever was coming here will not be going through anymore, right? You're going to slow down. It's like if you imagine this as a highway road, right? If you constrict something, then you basically have more lanes that are under construction now. So you went from having 4 lanes to 2 lanes, right? So things are going to flow slower. So your renal plasma flow decreases, which should be the first thing you think of as soon as you see anything about the efferent arteriole being constricted. Renal plasma flow decreases because you can't flow. Traffic is not going to flow that well. But your filtration rate increases. Why? Because now things are going to sit in here for a little longer than they normally were before, giving you more time to filter things, right? So the filtration rate increases. Rate is the thing about time, right? Every rate is like miles per hour or something like that. Rate has to do with time. So the longer things are sitting in here, the more time you have to filter. So filtration rate increases. Now, filtration fraction is GFR over RPF. If GFR is increasing and RPF is decreasing, that makes the ratio really big, right? So filtration fraction is going to increase when your angiotensin II is working. And you're going to do the opposite once you start using ACE inhibitors. You're going to cancel this out, so filtration fraction will decrease and go back to normal again. Right, so those are definite things you get questions on. You want to make sure you have that down. The last thing is this equation over here, right? Net filtration pressure. So when we did our capillary fluid exchange, we saw that PC and PI were about the interstitial fluid pressure, capillary pressure, interstitial fluid pressure. They were all about the pressure that can either push fluid out or into a capillary. And the pi things were all colloid, oncotic pressure, right? Colloid, osmotic, oncotic pressure. And these guys, the protein can't move, so the protein actually pulls fluid into or out of the capillary. And that's the same thing you're going to be seeing here as well. So same stuff, same equation. Just because some numbers are moved around doesn't change it. Actually, you can plug in numbers and check. It'll work the same. So I rewrote this equation. Right, you see how it's PGC plus pi BS, right? And I wrote here, let me actually make that a lowercase I, so it's more clear. Yeah. So you can see how I redid, because I'm a math major, so I know that you can move numbers around and whatnot. I rewrote this equation the same exact way as the capillary exchange fluid equation is written. I don't know why they changed up the order of the numbers just to complicate you, or maybe make things a little prettier. I'm not sure what they were really trying to do. But you can move numbers around. They're all just being added and subtracted. The parentheses don't have a major effect in that manner. And when you plug in numbers, you'll see, you can check my work if you want. Everything's going to be equal. And that's why, as long as you remember your capillary fluid exchange equation, you're going to be okay. And I always remember the capillary fluid equation as Chi-Chi. That's actually the name of my my sister's youngest cat. And, you know, CI is Chi-Chi, so you can always remember PC minus PI minus pi C minus pi I, which is the same thing for the renal stuff as well, right? PGC minus PBS minus pi GS minus pi bs. Right? And you always put the bs last because bullshit always comes last. You know, just make something up for yourself to memorize that. So I think I'm gonna die. I've been coughing for like 2 months. I gotta finish everything before I die. Yeah, so make sure you understand this because you don't want to be memorizing too many equations. Don't, you know, so it's all the same stuff. Just memorize the same equation. It's the same system. It's not like you have different blood vessels or anything like that. So net filtration pressure and capillary fluid exchange equation are the same thing. Just understand how they work and know how to use them. You're never really going to necessarily have to use them. You're not going to be given numbers to plug into this equation. It's more of a conceptual thing to understand how things work. But I don't even have any practice questions because that's how rarely stuff like that is ever asked. It just doesn't happen. Now this table, you know, a lot of students get very intimidated when they see this stuff. But this is actually pretty straightforward. We just finished talking about this, right? We talked about the ACE stuff, efferent arterial constriction, right? We said that when you constrict the efferent arterial, your plasma flow is going to decrease because traffic flow is going to decrease, and since things are going to sit in here for longer in the glomerulus, your GFR is going to increase. That means your filtration fraction is going to increase because the ratio got really big. ACE inhibitors stop this and do the opposite. And up here, afferent arterial constriction, right? Afferent arterial constriction. Look, PDA, prostaglandins dilate the afferent arterial. Afferent arterial constriction is something that happens on its own. And if you're taking NSAIDs, what is this about? Hold on. Afferent arterial constriction. NSAIDs prevent afferent arterial dilation. Yeah, this shouldn't be here. But anyway, afferent arterial constriction is something that can actually be upregulated if you're taking NSAIDs because prostaglandins are the guys that dilate your afferent arterial. So if you take NSAIDs, you stop that, which can then allow you to actually constrict your afferent arterial. So that's definitely something you want to be like ready with in a question scenario. You're just gonna see like very simple questions, just literally just testing you on whether or not you remember, right? So the remembering part is really easy just with this PDA and ACE, right? Prostaglandins dilate your afferent arterial. If you're taking NSAIDs, you're gonna stop that, but afferent arterial constriction is something that happens more so in hypertension, maybe renal artery stenosis, stuff like that. So what happens here? Well, again, with afferent arterial constriction, you're going to decrease renal plasma flow because it's still constriction of an artery, right? You're going to decrease renal plasma flow, but now you also decrease glomerular filtration rate because this is the afferent one, which means you slow down how quickly things are even reaching the glomerulus. So it's not like things are going to sit here for long. Things are not going to sit here for long. Whatever came, once it reaches, it's just going to go and keep going. Right? So the filtration rate, you know, GFR is more so affected by whether or not you make things sit here. Whereas renal plasma flow is affected by how well things can flow through the capillaries. And you can see renal plasma flow pretty much decreases all the time. The only time renal plasma flow increases is when you have afferent arterial dilation, which is what prostaglandins do. Right? Prostaglandins cause afferent arterial dilation, allowing more, it's like you added more lanes to your highway, so allowing more flow, so renal plasma flow increases, and since more things are flowing in, GFR also increases. Okay, so again, your filtration fraction is not affected. Main concept that I always summarize is that the afferent arterial, whether you constrict it or dilate it, it does not affect the filtration fraction because whatever you do to the afferent arterial equally affects renal plasma flow and glomerular filtration rate. Right, so renal plasma flow and GFR are equally affected. That means the ratio of filtration fraction stays the same. Right, so if you ever have a question about doing something to the afferent arterial, the filtration fraction will not change. The efferent arterial, though, is a different story. If you cause efferent arterial constriction, you slow down flow, so your renal plasma flow decreases, and you keep things in the glomerulus for longer, so GFR increases, FF increases. Now, these two next ones are about plasma protein concentration. So if you have high or low plasma protein concentration, that has nothing to do with renal plasma flow. Plasma flow is still going to keep flowing. But the proteins can decrease filtration rate. Right? So if you have a high plasma protein concentration, GFR decreases. And if GFR decreases and renal plasma flow doesn't change, your filtration fraction decreases. Similarly, if your plasma protein is very low concentration, then you're going to be able to do more filtration because the proteins won't get in the way, and that's also going to increase filtration fraction. So basically, plasma protein concentration and filtration fraction are indirectly related to each other. This next one, a constriction of a ureter. So we saw you can have constriction of a ureter for many reasons. BPH, just earlier, we did a question in the last video about this thing right here in the middle, amboss, where a guy had a common iliac artery aneurysm, compressing one ureter. That's another way you can constrict a ureter. Many things can cause constriction of ureters, and the main thing is if you constrict ureters, right? Just remember, this is not part of your filtering system anymore. Remember from embryology that the ureteric bud, right, gave you all your collecting systems, which had the ureters in it, and your metanephric mesenchyme gave you a filtering system. Constricting the collecting system just decreases filtration rate. It does not affect renal plasma flow. Alright, so this constriction of ureter, again, just slows down your filtration rate, so lowers your filtration fraction. Anytime you lower your filtration rate, chances are you will lower your filtration fraction because those two things are pretty related. As you can see, filtration fraction is directly related to GFR because GFR is in the numerator. The last thing, this one wasn't in the book, I added it, ANP and BNP. Your atrial natriuretic peptide actually dilates the afferent and constricts the efferent. So it's a combination of a couple of things we're seeing here, right? If you dilate the afferent, you're going to allow more things to come in. But if you constrict the efferent, then more things cannot come in because the things that are already inside are not exiting. That's why ANP and BNP effectively reduce renal plasma flow, right? Normally, if we dilated the afferent, we increase plasma flow because more things are coming in. However, this also constricted the efferent, so more things will not be coming in because things were not exiting, so everything kind of backed up. However, no matter what, whatever backed up and whatever's coming in, stuff is definitely sitting here for longer, so GFR goes up. Right? So with ANP and BNP, your GFR goes up, your renal plasma flow decreases, and of course, again, filtration fraction becomes really big. So this effectively looks very much just like efferent arterial constriction. Right? Whether or not you dilate the afferent, constrict the afferent, remember it had no effect on filtration fraction. Alright, so ANP and BNP, the more important effect it has is the fact that it constricts the efferent, thereby reducing renal plasma flow and increasing filtration rate by keeping things inside the glomerulus and increasing filtration fraction. All of the things in this table make sense. So you want to learn it logically. You don't want to memorize it. This is not a table you're just going to sit and repeat to yourself and memorize. It's just logical understanding of how things flow through a tube. So this was a rapid question asked by USMLE RX. They're just like, will the filtration fraction of a patient in the early stages of shock be higher or lower compared to a normal filtration fraction? So every time you think of shock, you should immediately think of hypotension, right? Generally speaking. So the answer here was higher. Patients in shock are not getting enough blood to their vital organs, so their renal plasma flow will be low, and their body will respond by selectively dilating the afferent arterial and constricting the efferent arterial. One of the things that ANP and BNP does. The main thing here is the fact that you constrict the efferent arterial. This will increase the net hydrostatic pressure gradient and raise the GFR. Since GFR is up and renal plasma flow is low, filtration fraction will be high. Right, so this ANP and BNP part is kind of related to shock. Right, and always remember, whatever you do to the afferent arterial does not affect filtration fraction. This was actually a very interesting question from UWorld. It came with this graph in the explanation. So they asked, they gave you this graph and then they asked, why is there a dip in the GFR after constricting the efferent arterial past 2? Right, so this, on the x-axis right here, you're seeing efferent arterial resistance. Okay, starting from 0 to 2 to 3 to 4. On this y-axis on the left side, you have the renal blood flow. And on the right side, you have glomerular filtration, GFR. So renal blood flow, GFR, efferent arterial resistance. Because remember, everything is about the efferent arterial, not so much the afferent. UWorld loves combining 2 to 3 graphs with 2 to 3 lines all into the same graph. They feel like they must think they're so smart for doing it. They must think they're so cool about it, but it's really not that, as a math major, it's not that big of a deal, but I totally understand how, for those who are not math majors, for them it's like, why? Why even do this? This is so annoying. Why can't you just show me two different graphs and ask me to evaluate them? But that's kind of what's happening here. You can always imagine this to be two different graphs where you have two different x-axes and the same y-axis. You can make two different graphs. You can pull them apart and keep the lines the same, and you can read them separately because a graph is always meant to be read. For example, this green line, what you're seeing is that as you go from 0 to 4, it increased to up to 2, and then it started decreasing. And then for the dashed line, you can see it's always decreasing no matter what. What's decreasing? Well, that's what your y-axes are about. You have two different y-axes so you can understand what's decreasing. So their question is literally about why is there a dip in the GFR after the constriction resistance of 2. Right? So as you're constricting your efferent arteriole, GFR was increasing, which we already talked about, right? Because if you constrict your efferent arteriole, things are not going to exit. They're going to sit in the glomerulus, and you're going to have more GFR. However, after constricting to a certain point, filtration rate also started decreasing. Why? So you would think that something's probably going bad, right? Constricting the efferent arteriole decreases renal plasma flow, which leads to slower capillary flow and more filtration, right? So a higher GFR across the basement membrane, thus increasing glomerular oncotic pressure. This increased oncotic pressure, which is the correct answer, can eventually overwhelm hydrostatic pressure from efferent constriction and decrease GFR. So what happened here? Remember I was saying earlier that if you constrict this, right? So let's say I constrict it so that, this much of the lumen is gone. So now it's half the size, right? Then whatever's flowing through here, right, will slow down now because, the lumen got really thin, and slow down and go very, very, very slowly now, right, until it gets through. Because it's slowed down, more things are going to be sitting in here. And if it's all sitting in here, that allows you to filter for longer, so you have a higher GFR. Eventually, if I keep blocking this, right, so that's the part of going past 2 on this graph, going past 2. Eventually what's going to happen is too much shit is backed up here. And some of that shit is going to be the high plasma protein concentration. And you see how high plasma protein concentration decreases GFR? So much shit is going to back up in here that you're also going to have a lot of proteins here. And the oncotic pressure in here is going to start decreasing GFR. How do you tackle such questions? What if you can't remember that? What if you can't remember the protein concentration part? What if you just can't think of this? Things you want to imagine in your mind is, filtration rate was increasing, now it's not. What are things that can reduce glomerular filtration rate? And the only thing that truly reduces glomerular filtration rate is a high plasma protein concentration. That's it. Right? Constriction of the ureter doesn't directly reduce GFR. Constriction of the ureter also eventually increases plasma protein concentration, thereby reducing GFR. Right? The afferent arterial constriction was a whole different idea. Yeah, it reduces GFR, but it had no effect on FF. It reduces GFR because you're really not letting things in to begin with. Nothing's coming in, so there's no filtration. Right? But the main thing, the main primary guy that really reduces GFR is this right here. Right? High protein concentration. So basically, after this point, there was so much protein in your glomerulus that GFR started decreasing. That's what's happening here. Okay? So you don't get too confused when you get two different graphs and many different lines and axes in the same image. You just got to read it one at a time. Break it up into two graphs, break it up into multiple pictures in your mind. Obviously, don't waste time drawing it. And just read each thing separately. I read this y-axis first, then I read this y-axis, and then I figured out, what's happening at this 2 point. And it's very clear. They told it to you already that things are decreasing after the point 2. Now it's just up to you and your renal physiology understanding to figure out why that was the case. Alright, so yeah, always remember, afferent arterial constriction, dilation, efferent arterial constriction, dilation, completely different scenarios. One of them allows more things to come in. The other one slows down whether or not you leave. The main difference is that afferent is before the glomerulus and the efferent is afterwards. So that's going to have different end scenarios. And then the last thing was this question right here. Given the data below, what is the net filtration pressure? right? So in case you do ever get a question about net filtration pressure with information verbally being provided, so they tell you glomerular capillary hydrostatic pressure, oncotic pressure, Bowman capillary hydrostatic pressure, oncotic pressure. You label them, you figure out where they all go, and then you just plug them into the equation. So the equation the book gave you would work like this, where you would take the PGC and add the pi BS, 45 plus 2, minus 10 plus 27, and that gives you 10. It's the same if you do it with my equation, where I just reorganize this so that all the hydrostatic pressure is on one side, all the oncotic pressure is on the other side, and you just subtract them. That's it. Everything is subtract. I don't like the way the book had the equation because there's pluses and minuses, and you can mess that up. That's too much extra stuff to remember. Look, PGC plus pi BS minus PBS plus pi GC. That's too much. This equation is a lot better. Everything's minus and everything's paired together. Glomerular minus Bowman minus glomerular minus Bowman. Oncotic. Okay? Very easy equation. Nothing crazy about it. You can just use it however you want. If you like the book version more, then go for it. And just never get this wrong. Never get this wrong. This is just straight up math and plugging in numbers. Elementary. Very elementary. In the next video, I'll go on into the rest of these things over here, and we can talk about all the different parts of the nephron one at a time, look at some more pictures, and really jump into acid-base physiology later on. Okay, so 2 more videos should be enough to finish up renal physio, but yeah, I'll see you guys in the next video, and then we'll continue on.